Ketorolac better for renal colic than Advil?
No. It's good when someone's having bad renal colic and they're often nauseated and you're looking for speed of onset, I think, is what your goal is there. Plus, they're not going to throw up, so it's really good for that.
So this is a big topic because, one, it's the number one thing we do basically in the pre-hospital setting.
Mm-hmm.
And I could tell you from my own personal preference that it'd be so intuitive to hear from you on your analgesic practices and how we can apply it to the pre-hospital setting.
Sure. So it's clearly very important for an emerge physician standpoint. It has always been historically something that we don't do a great job of. People tend to be hesitant to use narcotics. They tend to underdose them. And also nursing tends to be sort of hesitant to keep up with the schedule. So I'll put it into perspective. Let's say I have someone come in with renal colic. I will immediately give them Ketorolac. I'll give them 15 of Ketorolac. And I will give them 10 milligrams of morphine typically at the same time, depending on their size, like anywhere between 5 and 10. So I'll do that all at once, and then I will repeat a 5 milligram morphine dosing every 20 minutes. What I will tend to see is that they'll be administered the initial dosing, but may never they either don't get another dose of morphine or it gets delayed to 40 minutes, 45 minutes, and I think it's because of hesitance to administer doses that high. With understanding that if you give somebody 0.1 per kilo of morphine, that will relieve pain in an individual 50% of the time. So your average is 70 to 80 kilos, so 7 to 8 milligrams will relieve 50% of people. So you tend to have to give fairly significant doses to relieve the majority of people. So I'm fairly aggressive. That's why I tend to give 10 up front, because again, that'll be close enough to sort of an 80 kilo individual that will help to treat them. But again, that's only 50%. So I don't top out on my doses of morphine. I'll actually continue administering. So I think, similarly to where the paramedics have the option of giving 10 and then repeating, I think it's important to be able to take advantage of that dosing so that they can attain good analgesia. If you're careful, I have never had an emergency patient develop any sort of respiratory depression from the doses that we're giving. The elderly inpatient hip fracture, that's a bit of a different story, but if somebody's coming in with acute pain, I've never had that happen. I use fentanyl less frequently in emerge, and I think fentanyl is great for the pre-hospital environment because it's short-acting. Whereas in emerge, you're probably looking for something that's a little bit longer acting to help to maintain the analgesia. So I tend to use fentanyl more for procedural things where they're going to be receiving some sort of anesthetic agent plus a narcotic where there is significant risk of you causing respiratory depression. So you want to have something short-acting that'll, if you do run into that trouble, it'll wear off. But still a really good analgesia choice. And again, for pre-hospital, it allows you for monitoring and that type of thing as well.
So much to unpack there. That's interesting. And everyone has their bias, right? They're like, I like morphine, I like fentanyl. But you said fentanyl's really good in the pre-hospital setting because it's so short acting. Mm-hmm. And correct me if I'm wrong, fentanyl's better probably for trauma.
Yeah.
Okay.
So traumas are very dynamic. Their volume status, their level of consciousness. So fentanyl allows for immediate management of pain, but allows, I think, for better management of the patient in the sense that, if things start to get a little soft blood pressure wise, your dose of narcotics is going to wear off quite quickly, whereas if you've loaded them with morphine does vasodilate you, you can potentially exacerbate the problem if you're not careful. So And also for monitoring the level of consciousness and that sort of thing, knowing that you didn't do it with your narcotic, that maybe their level of consciousness is altered because of the trauma. So I think there's a lot of advantages for using it in trauma.
What about morphine for cardiac ischemia then?
So it's really sort of hypothetical. So the reason morphine is used for cardiac ischemia and not fentanyl is based on some older, probably more observational data that shows that there may be a worsening of outcome with fentanyl. But it's again really sort of soft, that literature, and probably not real, I would say. So it remains as it is in our directive because there is availability of both of those medications. But we have had actually some discussions provincially about whether or not to enable fentanyl to be used for cardiac ischemia. And again, the decision was made is because the morphine is already there, it's used, everybody's comfortable with it in that scenario, we've left it with morphine.
That's good to know, because I can tell you anecdotally, and I've heard this echoed from a lot of paramedics. We go to like the cath lab and we're like, why are you using morphine? And we're like, I don't know.
Yeah, I mean, ultimately there's this theoretical, obviously you're making the patient feel better, but also theoretically, if you're improving their pain, you reduce their myocardial workload, et cetera. Again, it's, I think, a lot of sort of hypothesis as opposed to really being any sort of evidence. But nonetheless, I mean, part of our job is to treat pain. So I think it's very reasonable to do that.
And the mechanisms too, like you said, morphine can lower your blood pressure. So whenever you want that, if someone's stable enough to drop their blood pressure enough to reduce the myocardial workload?
Yeah, it's probably doesn't have enough of an effect to really matter, to be honest. Yeah. You're improving their pain somewhat. Again, ultimately, their pain is being caused by this fixed lesion, so there's ongoing ischemia. So, whether or not reducing their pain has any really significant effect on their blood pressure is debatable. But again, I think it really just comes down more to the patient comfort.
That makes sense. I love that you said you'd give morphine for the renal colic with the NSAID, because that's the key. You should combine an NSAID with an opiate.
Yeah, so the NSAID is great. With the antiprostaglandin effect, it's still going to end up taking probably 40 minutes for that to start to work. It sometimes works really well on its own. It sometimes does not work really well on its own. And so in cases where the person is in a lot of discomfort, I don't want to wait and see whether or not this one works before administering the other. When we know what co-administering them is safe. So I just give both at the same time, try to get their pain settled as quickly as I can.
Is there evidence to suggest morphine's better for renal colic versus fentanyl?
No, it doesn't matter. It's whatever analgesia agent you choose to use, so long as you combine it with the NSAID for the antiprostaglandin effect, it doesn't really matter what you use.
Correct me if I'm wrong on this, because I was reviewing all this, and it's low-quality studies, I believe, but they're like, there is no real difference between morphine and fentanyl in the pre-hospital setting, besides some differences in pathologies.
Yeah, it's not, it definitely does not really make any difference. It's other than the short-acting effect of the fentanyl, I mean, you're still administering a good analgesic agent, so I think they're both fine.
Does one have more side effects than the other?
No, not really. No, I can't really think of it. There's some people who get a little bit of histamine release when they get morphine, but that's, the people will typically tell you that they're allergic to morphine, but that's really actually what happens, is they're just getting some local histamine release, and which tends to be less frequent with fentanyl, but that's about it.
What about the nausea vomiting?
Again, fairly hard to say. They don't do a lot of head-to-head comparisons of fentanyl and morphine. Like morphine compared to, say, hydromorphone is a little bit more nausea-inducing, but morphine, generally speaking, is actually pretty stable from a nausea standpoint. It's not, which is why we don't routinely co-administer a nausea medication with it. Fentanyl is the same. Again, really has not, like, it can cause some nausea, but it's not a significant side effect. So they're fairly similar that way.
Is there anything to substantiate if you fast push like the morphine, it can increase nausea vomiting?
No, that doesn't seem to make any difference at all.
So you'll like this. I'm sure you've heard this, that people will co-administer automatically morphine and gravel to overall have that kind of synergistic sedative effect.
Yeah. It really is not recommended. There's actually probably significantly more side effects from the gravel. So I do not routinely administer any gravel with it. You sort of raise a bit of a good point as well too, is that what I have found both in the emergency department and pre-hospitally is that people will administer morphine, let's say you give 10 milligrams of morphine, and there's not any relief from it, and the people want to switch to something else. So they want to, because it's not working. So they'll want to switch to fentanyl, or they'll want to switch to ketamine or something like that. And so going back to what I originally said about like the 50% of people will get relief at that dosing. There's some people who need very significant dosing. And so it's where you run into risk is when you start flipping different medications that have slightly different pharmacokinetical profiles, and so better to stick with one agent. I would rather go big on morphine than start flipping back and forth and trying to mix things together.
I can tell you that from an education side, I think we just create this artificial barrier when they see the medical directive for an adult, like 2 to 10 milligrams, your max dose is whatever. And if you pass that, they're like, I'm going to overdose this patient. But in the grand scheme of things, it's very conservative, safe dosages, right?
Absolutely, yeah. And that's really why we changed that directive to enable those larger doses, because it's safe, it's effective, and you may need to give a lot to get them comfortable.
I guess that's dependent on their age, their weight, if they're on narcotics at home.
Yeah, because they'll be tolerant to them, so bigger doses. If they take other drugs like marijuana, they tend to be more resistant. So there's definitely other factors that contribute to your sensitivity to those medications. But to your point as well is that, you know, if it's an elderly person who's on a carload of other things and some of them may be sedating, you maybe want to be a little bit more judicious in your application of those medications. Whereas a 35-year-old person with renal colic, you can just sort of bang away and you'll be fine.
Why does marijuana increase their...
There is I don't know the mechanism, but it does increase, like it upregulates the enzymes that metabolize it, so they metabolize it very quickly. We have the same issue when we are using things like propofol for sedation, is that they tend to take very large doses of propofol, and because they've upregulated all of these pathways to metabolize them.
Is that like a chronic user or like?
Yeah. If you use marijuana, occasionally, that's not going to make any difference at all. It's people who tend to use it fairly frequently, like on a daily basis.
What are the high-risk groups then? Because you mentioned that, like the elderly, we have to be careful of. What other high-risk groups should we be careful of and maybe give lower dosages?
I think there's the obvious things that people they've been drinking, so they've already got a sedative hypnotic on board. If they are, chronic benzo use, sedative type medications that they're taking. People with chronic lung disease where they may be more sensitive to something that's going to alter their respiratory drive. So if they're on HOMO-2, like if they're asthmatic, I wouldn't worry about it. But if it's someone who does have COPD and maybe on HOMO-2, you have to be careful with those as well. Any sort of polypharmacy where there's the risk of different medications interacting with each other, you do have to be careful about the sedating effects.
What about like renal failure, liver failure patients?
Not as much, because even if you do have some degree of inhibited metabolism with those, you're still fairly safe using narcotics, because their sensitivity to the narcotic is not going to be any different. It just maybe will hang around in their system longer. Different for, again, you're not going to give Ketorolac to somebody who's in renal failure, but otherwise it doesn't seem to really make a huge difference, I don't think. I would never, sorry to interrupt, I would never, like if someone was a dialysis patient having a lot of pain, I would not hold back on giving them morphine or fentanyl if they needed it.
It's funny you mentioned the HOMO2 at home? Because I could tell you, like, anecdotally, how many times we've been to the patient where they're on HOMO2, they tripped on their action tubing and broke a hip, and you're like, oh, I could depress your respiratory drug fairly easy.
Which is kind of, again, it's sort of one of the nice things about having fentanyl, because it's short acting, and so if they are showing some signs of decreased respiratory drive, if you sort of support that, it's probably going to wear off pretty quickly. So as opposed to morphine, which is going to linger in their system for hours.
What about this chest rigidity that can theoretically occur with fentanyl?
It's very theoretical. I'll be perfectly honest, I've never seen it.
And correct me if I'm wrong, isn't it like induction dosages, like fast push that?
It's usually for anesthesia induction, where it's theoretically going to happen. But again, I've never encountered it.
That's good to know.
Yeah.
What about ketamine then? Like, would you suggest paramedics just move to ketamine right away if they have somebody that's at a high risk of stopping breathing?
No. I think we've got a lot of experience using those particular types of analgesics that we have, and paramedics are also very good at doing respiratory support. You also have naloxone if you get yourself into a pinch. So I still think that those should probably be the go-to. I think where ketamine has shown its value are in those people, really, like at least in my own experience, where either you've required very significant amounts of narcotics and you're not getting anywhere, so you need to try something else eventually because you're not getting them settled. Or B, if you're really uncomfortable about utilizing a narcotic, so in situations where somebody is a chronic narcotic abuser who may have extremely high resistance to narcotic doses, it's a good option in those situations.
I can tell you from the education we did for the 5.4 medical directives, a lot of people want to know, like, when do I integrate ketamine? Because they want the black and white answer.
Yeah.
And it's like, truthfully, I don't really know what to tell you. It all depends.
No, it's going to vary from person to person. I personally use it very infrequently. The only time I ever use it is somebody who has sort of acute on chronic back pain, where it doesn't matter how much narcotic I've given them, I can't get them to ambulate, I can't get them to move, and so I'll move to ketamine as sort of, this is the last resort before whether or not I have to consider admitting the person for analgesia. There are other people who use it probably more liberally than I do, but I'm very comfortable with the choices of medications that we have. I think like morphine and fentanyl are tried and true, they work well. So I'm very comfortable with using those. So ketamine for me is sort of a backup to those. I mean, there's some, I think, good literature that shows that it can provide equivalent analgesia to narcotics, but it's not superior. So I think that's the important thing, is to recognize this is a thing you have in your toolbox that you have available to you, but it's not a better drug than the stuff you already have. It makes sense to enable using it because we have it for the combative patient. So we're trying to enable further use of it, but again, you have lots of analgesia choices, so you can use decision making in those situations.
And that goes back to what you said, like if 50% of people respond to 0.1 milligrams of morphine, maybe that's still suboptimal dosing, I'll try more morphine.
Yeah.
And you don't have to rush to ketamine.
Absolutely.
So the example, like you tell me your perspective on this that I gave, it's like maybe if someone has a traumatic amputation or like significant burns, I'd try fentanyl and maybe move to ketamine quicker than I would for somebody with any other type of pain.
Yeah. I think the other thing to recognize as well is that, so the doses that are being given for pain are sub-dissociative doses. The person you're not using it in anesthetic doses, because I think there's maybe some perception that in that situation it will help to either make them forget or help to sedate them more. But we're using very low doses of it, and so it's not being used for that at all. It's strictly being used in a pain dose. So I think that's a good example, though, that you gave.
Yeah, because it's anxiety license. You're not so supposed to sedate them because that comes with the risk and everything.
Yes.
We just want to achieve analgesic dosages.
Right.
And if you combine like fentanyl and ketamine, that leads to opiate sparing effects, right?
Yeah.
So you give less opiates overall.
Mm-hmm. Right.
That's good to know. So this is a good question that I'm sure you heard a bunch that I would love to clear up. Ketorolac. Why do we give 10 to 15 milligrams?
It's a good question. So there is actually evidence that the ceiling dose of effectiveness for Ketorolac is 10. More than that doesn't work. Originally, and this is why it's packaged the way that it is, it used to be 30. Everybody got 30 of Ketorolac. Sometimes people would give 60 because more is better. But the ceiling dose is 10. Ultimately, for ease of administration, 15 is easier to drop and administer than 10. And so that's really where that number has come from.
So if someone drew up whatever mils equates to 12 milligrams, could they do that?
Yeah, absolutely.
It has been done.
Yeah, for sure. And that's not underdosing them. Again, 10 is really the effective dose, and beyond that, it's very similar to all the other NSAIDs. So the ceiling dose that's been demonstrated with ibuprofen is 400. So whether or not you give them 600 or 800, other than risking giving them gastritis, you're not giving them any extra relief by doing that.
Because I'm sure you heard, well, the hospital gives 30, why do we give 15?
So most hospitals you will see give 15. There are still some that are throwbacks to when we used to give 30, and they haven't really changed. So that's where you will see that. But that's really a throwback to older medicine.
And the overarching theme is what happens in the in-hospital setting does not dictate your practice in the pre-hospital setting.
Absolutely.
Could you theoretically, I don't know why you do this, mix Tylenol with Ketorolac?
You mean sort of pre-hospital?
Yeah.
Yeah, I could. I mean, it's silly. So Ketorolac, to put it into perspective, pretty much all of the NSAIDs are equivalent as far as their effectiveness. Ketorolac's the only parenteral one. So giving a dose of Tylenol plus Ketorolac would be the same as giving a dose of Tylenol and Advil. So you would get the same benefit. Yeah.
Logistically, it just would be kind of strange to do an injection versus a pill.
Yeah.
So is Ketorolac better for renal colic than Advil?
No. It's good when someone's having bad renal colic and they're often nauseated and you're looking for speed of onset, I think, is what your goal is there. Plus, they're not going to throw up. So it's really good for that. Prior to Ketorolac being available, people used to be given indomethacin suppositories for the same reason they can't throw it up. But its speed of onset was not that much faster than if you gave anything orally. So that's where Ketorolac is really nice.
Because for years the education was Ketorolac's the main drug for renal colic. And I guess some new studies came out and they're actually equivalent. It's any NSAID, right?
Yeah.
So it's good we're hammering that point home.
Mm-hmm.
Okay, you'll love this one too. Imagine we have somebody in severe pain. I give them fentanyl. And they still haven't responded. Then I follow up with Advil and Tylenol to hopefully hit a different pain pathway, and that kind of helps each other. Can they do that?
Yeah. Yeah, absolutely. They all metabolize differently, so it's fine to have those all in your system at once. Yeah.
So would you recommend them giving all at once, or let one peak, see how they respond to it, then kind of follow up with other medications?
Yeah, I think it ultimately comes down to how fast you're trying to achieve what you're getting to. With any of those oral medications, again, you've got about 40 minutes until they start to work. So they'll probably be starting to work when you arrive at the hospital, but they may not be doing much while you're getting there. So if you think it's pain that would respond to those things, I think it's reasonable to give it early, and then you can give fentanyl while you're bringing them in, and then maybe those are kicking in by the time they arrive, and hopefully will help to sustain their relief, because again, they're longer acting than the fentanyl would be.
Because that bridges into our unique problem in the pre-hospital setting. You hear a lot of paramedics say, well, I'll give morphine for this patient because I know I'm going to be on offload for like 8 hours because it lasts longer versus fentanyl. What do you think about that practice?
It's not a bad idea. And this is the reason, I don't use fentanyl for management of pain in the emerge typically for that very reason. They're going to be there for a while. realistically, they're not going to get frequent repeated doses of fentanyl. The staff don't have time to to administer that. So I do prefer using stuff that's going to last longer.
Makes sense.
Yeah.
You can do aliquots too, kind of spread it out.
Yeah,
slowly.
absolutely. Yeah.
Would you suggest paramedics patch for hydromorphone?
No. The short answer. It's we use it in the palliative directives mostly because of the nausea effects for hydromorphone are less. Hydromorphone's a much more potent drug than the other ones are. So lower doses provide similar amount of analgesia, and palliative patients are often on very significant doses of narcotic already. So you'd never reach those types of thresholds of analgesia with the morphine or fentanyl. But the risk of using hydromorphone in the routine 911 patients is that you're potentially going to give them way more than you may need. And so there's increased risk of having side effects from it.
And if you had a palliative patient that was going to the hospital, not staying at home, and they're in severe pain and on hydromorphone, would you recommend paramedics patching to give them their narcotic therapy?
I think that would be reasonable, yeah. Yeah.
Good. So just echoing what we've been further going.
Yeah.
To tie it all up, any last thoughts that you want to tell for analgesic purposes?
Just don't be hesitant to do it. Even if the person is uses narcotics, you have the suspicion they may be a narcotic abuser, that people can still have an acute medical event even if that's the case. And so our job is, yes, to be cognizant of that, but also to make them comfortable. So I would not err on the side of going light on the narcotics, recognizing these people probably have a very significant tolerance to narcotic. I think I would just treat them the way that you normally would. So if someone had an injury but they have a history of narcotic abuse, I would still make sure you're treating their pain. The one thing I would do is, before doing that, is ask them if it's okay. There are some people who have a history of narcotic abuse who've come off of the narcotics, and it doesn't matter how much pain they're in, they will insist that you don't give them any. And so always confirm with the patient that it's okay to give it to them before you do.